Audience, thank you so much for joining Medical Mondays with Dr. Toyin Opisami, MD, American Academy of HIV Medicine Specialist, for an exciting conversation about your health. Medical Mondays introduces health information, medical facts, and possible solutions as we examine health challenges to enable each one of us to live our absolute best lives. Whether providing high quality medical care for families and individuals through Genesaret Medical Center, providing care for vulnerable communities through Global Vision Health Center, or providing medical missions in the US and abroad, Dr. Opisami is committed to changing lives through healthcare wherever she goes, one person, one family, and one community at a time. Medical Mondays provides an opportunity to explore healthcare with one of our nation's leading community health advocates and world-renowned medical missions expert, Dr. O. Audience, if you have questions as you listen to Dr. O and our Medical Mondays guest today, please jot them in the chat box or raise your hand and you'll be recognized to ask your question. Now, grab your pen and paper, lean in, and get ready for an enlightening conversation about our brain and aging and brain health. Dr. O?
Thank you. Dr. Onyike comes to us with expertise in mental health, especially, in dementia, brain health, and all that encompasses. He's one of our professors at Johns Hopkins, the Johns Hopkins. So, bro, I'm just going to give it to you so we don't belabor this any further. And thank you again for coming.
Thank you again. I'll pull up the slides. So I'm going to be talking about aging and brain health. And when we do that, we inevitably talk about disease. So I'll give you a little information about why it is very important to be focused on brain health. I'm not going to be talking about clinical trials. I will not dwell too much in this conversation on medicines, but if they come up in the questions, I'll be happy to take any relevant questions. As we all know, there's a high burden of Alzheimer's disease today, and this is the reason why discussions about aging and its relationship to cognition and to brain health have become very topical. The burden of Alzheimer's disease worldwide exceeds 6 million today. The data that you see on that in the graphic in front of you comes from the Alzheimer's Association, but this is from 2017. There's more recent data. I haven't had the time to update it accordingly. What you'll notice is that the burden of disease globally has risen steadily over the last 10 years. And the projections are that it will be very high in the year 2050, exceeding 12 million. Today, the highest burden is in African Americans and Native Americans, so it's in minority groups. And that's in terms of cases per 100,000. And there are a number of reasons for that, but I'd like to first talk about cognitive decline with age. So not all cognitive decline is associated with dementia. It is natural for cognition to change as we age. Some of this one might term decline, but a lot of it has to do with changing patterns of cognitive processing. So as we get older, we rely less on original computation and more on pattern recognition. So that's why, as you know, if you recall, when you're younger, parents will typically give advice, and that's usually based on I've been there, been there, done that. So it's experience, and experience allows one to take, if you will, shortcuts to identifying scenarios, identifying and predicting outcomes, essentially. It turns out that when people do cognitive assessments of methods of testing, typically decision-making is superior in older adults, even when computational processing does not necessarily match that of younger adults. Now, the graphic to your left, to your right, shows that is a graphic about brain abnormalities over time. So this is the deposition of amyloid protein in the brain over time. And amyloid protein is relevant to Alzheimer's disease, as I will tell you in a minute. What this graphic shows you is that the rate of amyloid positivity, which is, increases over time, but even so, a lot of people continue to have normal cognition. So the darker lines are those who have essentially normal cognition. One of those lines, which is denoted by SCI, which is subjective cognitive impairment, which basically means that people are concerned about their cognition, but they don't exactly have any abnormalities. They're just worried about it. So these people we will classify as normal. Whereas MCI refers to people for whom there's a cognitive complaint, and when we test them, we identify a memory problem, but it is not sufficiently severe to warrant a diagnosis of dementia. So what you'll see here essentially is that amyloid deposition in the brain increases in time, but is not necessarily associated with cognitive decline or dementia. So this is an important thing to keep in mind. Now, the incidence of dementia, so I've told you that the burden is increasing, is high, and is expected to increase in time. That's because the incidence of dementia in the world, and in the US too, is increasing. It's been increasing, and as we know, the frequency is also higher in older age groups. So this graphic shows you, batches the data according to age groups, 5-year increments, and also puts graph lines according to racial background. So what you can see again is that the incidence, not only is the burden highest in minority groups, but the incidence is also highest in these groups. And so we'll be having a conversation about why that is so. Why have we so far emphasized memory? Well, this goes back to Alzheimer's disease, and Emil Kraepelin termed this the disease of forgetfulness after Alois Alzheimer had described it. Alois Alzheimer, you'll see to your left. August Dieter is the person you see to your right. She was in her 50s, incidentally. She was in her 50s when Alzheimer first met her. And at that point, she already had a severe dementia. She was very forgetful. She couldn't remember recent events, but she also no longer could remember much of her biography, what her name was, who her family were, and so on. In addition to that, she had a number of behavioral problems. She also had difficulties in other areas of cognition. So it wasn't just rapid forgetting and forgetting of the past. There was also disorientation. She didn't know where she was. She didn't know why she was there. She had trouble naming or even recognizing everyday objects. So he recorded her progress over time. And after her death in 1906, he examined her brain. And it is that clinical description alongside the pathological descriptions that together defined Alzheimer's disease or what was called the disease of forgetfulness when the disease was first described. This is what Alzheimer would have described. This is not August Dieter's brain. Firstly, shrinkage in the brain, denoted by this widening of spaces, which we call sulci, and the thinning of what we call gyri. So if you notice back here in the occipital areas, which subserve cognitive visual processing, the brain packing is tighter, whereas in other areas of the brain, there's much shrinkage. What I've mentioned amyloid. Amyloid are extracellular deposits in the brain, but outside the brain cells that are found in Alzheimer's disease, but also in older adults who have normal cognition, as I have also mentioned. You also have what we would call tangles, which this is an example of a tangle. This is essentially a ghost cell. So this is a dead cell, and it is being clumped, if you will, by what is called tau protein. And it is this dead cell that we call tangles. And so what Alzheimer did was to describe the plaques, the tangles. This tangle is next to a plaque, which you can see here. And then when you look at it in lower magnification, what you see are a lot of plaques, as you can see here, and a lot of tangles, which here in this image look like tadpoles. And it is these two findings together that constitute Alzheimer's disease microscopically or pathologically. But Alzheimer's disease is not the only cause of dementia. And this is important to keep in mind as we go into talking about why the incidence, the frequency varies by racial groups or ethnic groups. For example, vascular dementia, this is a disease caused by repeated strokes. Some of them may be overt, meaning that everyone can recall a time when the person had a stroke. But sometimes the strokes are not overt, they're covert, or what we call silent. And so the person no one is aware, not even the individual is necessarily aware that they've had strokes. But this can translate over time to the erosion of cognition, as well as to psychiatric problems. There are other kinds of dementias besides Alzheimer's disease and vascular, but for the purposes of our conversation, we'll keep it to this. So there are risk factors for dementia. Age, as you may already have discerned, is the big, or as you may already know, is the big one. So the frequency of dementia is age-related. It increases with increasing age. Even though aging is not necessarily, dementia is not an inevitable outcome of aging. This is a very important point to keep in mind. Family history, meaning that if a person has a relative with Alzheimer's disease, say, the risk for getting Alzheimer's disease is about 2.5% higher than would be the case for some, in comparison to a peer who does not have a family history of Alzheimer's disease. There are also genetic risk factors. The apolipoprotein E4 allele has been associated with a higher risk for developing Alzheimer's disease. Now, this is not necessarily hereditary. So you can have a double copy of an E4 allele. So you get one allele from each parent. And there are 4 alleles, ApoE1, 2, 3, 4. The one, ApoE4 is the one that's associated with Alzheimer's disease. This association is stronger in Caucasians than in people of African heritage. This association does not determine that a person will have Alzheimer's disease. So you can have an ApoE4 allele, a double copy, and not develop Alzheimer's disease. But having that allele puts you at a higher risk for having Alzheimer's disease. Having had head trauma in the past, midlife obesity, hypertension, particularly uncontrolled hypertension, smoking, diabetes, these are very important risk factors for Alzheimer's disease. These are things that are disproportionately common. So many of them are disproportionately common, particularly hypertension and diabetes in the African-American population in the United States today. So this has to do to a degree with lifestyle. It also has to do with healthcare access and with treatment and with quality of hypertension treatment. Now, I should mention that if one were to cease smoking, to stop smoking, the risk for cardiovascular disease and consequently the risk for dementia diminishes over time, such that after 5 years of abstinence from smoking, one's risk in association with smoking approximate that of peers who never smoked. So for those who smoke, it's very important, their risk changes, reverts to normal essentially, if they stop smoking. The association with depression is still controversial. It remains uncertain whether, for example, at the moment, there isn't compelling evidence that having a lifetime history of depression puts one at a higher risk for dementia, for developing dementia. We also know, however, that developing depression in late life is associated with a higher risk of progressing to dementia. Whether that association relates to depression being the beginning of dementia, as opposed to a predictor of dementia is still uncertain. Sleep hygiene is very important. This is a more recent discovery. Sleep deprivation has been shown to be associated with one's risk for cognitive decline and for dementia. It also is associated with cognitive performance in real time. And it turns out that people have actually gone further and looked at this association. And sleep deprivation, chronic sleep deprivation, has also been associated with the burden of amyloid protein in the brain. And that protein accumulation over time seems to be accelerated by chronic sleep deprivation. So this is a very important issue. The association with cholesterol hyperlipidemia has not been established. So it remains uncertain that high cholesterol is associated with dementia. So to recap, brain injury, midlife obesity, hypertension, current smoking, diabetes, and to lesser degree sleep disturbances, but still significant sleep disturbances, and to some degree depression. Now, on the other hand, there is also evidence that that formal education is protective. Physical activity, cardiorespiratory activity specifically, is protective. Diets that are lower in carbohydrates, for example, the Mediterranean diet, also are protective, as is cognitive training in people who are at that age for risk. Alcohol consumption is also a risk factor, although the evidence is weak. And it remains uncertain if social engagement improves, is protective. But there is some evidence that that may be so. Now, there are three genes that I did not mention that you see on your left column. APP, the amyloid precursor protein, the presenilins 1 and 2. These are hereditary risk factors for Alzheimer's disease. Or to put it differently, mutations in these genes cause Alzheimer's disease, and mutations in these genes are passed from generation to generation. For those of you who understand medical terminology, this inheritance is autosomally dominant, which means one abnormal copy of the gene inherited from one parent as opposed to two, as opposed to both, will lead to Alzheimer's disease. It will typically be young onset, meaning people will develop it at about age 50 or 60. And it doesn't skip generations. So everyone who's a mutation carrier will develop the disease. The penetrance is 100% in that sense. Here's an example of a pedigree. Now, this is for a different kind of genetic mutation. This is for the C9 mutation that causes Alzheimer's, that causes frontotemporal dementia and ALS. But the principle is the same, which is that there's no generation skipping. And the mutation, the hereditary state, is passed from parents to offspring. And so you see the same thing here. And you only need one affected parent. So this parent does not have this parent here, for example, does not have an abnormal mutation. Neither does this one. But inheriting a single copy of the bad gene from one parent is enough to develop to be at risk for the disease. And if one is a carrier of the mutation, there's 100% certainty of developing disease. Now, fortunately, this is rare. It accounts for less than 1% of all Alzheimer's disease. Hereditary mutations account for less than 1% of all Alzheimer's disease. Now, for younger onset dementias, the proportion that are hereditary is higher, but the majority are still not hereditary. So we believe that for people who develop Alzheimer's disease before the age of 60, well over 70 to 80% do not have a hereditary condition. Now, what happens is, this is an insidious condition. Alzheimer's disease is insidious. It develops over time. Typically, most commonly, memory loss is the leading edge, but sometimes it can be difficulty with speech. It could be confusion about space or time. It can be confusion more generally, for not knowing how to do tasks, not knowing how to log into a computer anymore, not knowing how to put in one's password. Very rarely, it could start out with loss of motor skills. Over time, it progresses. What began first usually remains the most dominant problem. So if this is memory loss, it will continue to be the dominant problem over time. And it is these cognitive impairments and the associated functional problems that enable us to make a diagnosis, recognizing the pattern of abnormalities and then being able to measure them and to then bring technologies to the bedside. Those are the things that allow us to make a diagnosis. I'm not going to go over this now, but I can return to it when we do the Q&A. What I wanted to do, though, is talk about what we're doing when someone says get a brain MRI. Because when a doctor orders a brain MRI because a person has cognitive impairment, the reason to order a brain MRI is essentially to look at the structure of the brain. What does the brain look like if we can look past the skull? That's what the MRI does for us. In the panels at the top, what you see here in this case is atrophy of the frontal lobes. So you can see that the spaces here are wider, the tissue is thinner compared to the rest of the brain. So this MRI essentially makes clear that this is a case of frontotemporal dementia. Here, what you have is bilateral atrophy of the anterior temporal lobes here. So the temporal lobes, which subserve memory and knowledge primarily, are destroyed by the degenerative process. And that's striking here. This entire area should be filled with brain tissue, but that's not the case in this image. Here, what you have is loss of the perisylvian area, which affects language. Now, sometimes the MRI is normal, or the MRI abnormalities are subtle, and the pattern is unclear, in which case we might get what is called an FDG PET scan. So this is deoxyglucose, in which you're using deoxyglucose as a proxy for glucose. And the reason to do this is to create an energy map of the brain, because the brain requires glucose to function. So we give it fake glucose. We ask the person not to eat overnight so that the brain needs the glucose. We tag the glucose with a radioactive signal, not enough to harm the body, but enough to see where the glucose goes, and then we map it. What you see here, for example, is that the temporal lobes are not uptaking this fake glucose. Or to put it differently, the metabolism in these areas, here the temporal lobes, here the frontal lobe, here again the frontal lobe, are abnormal. So the people from whom these images were taken had normal MRI scans, but we can see that their brains are not functioning normally. Today, there have been further advancements. We can now tag amyloid in the brain. Now, as I told you, amyloid accumulates over time in the brain. We can now tag it. So we can inject essentially a tag, which is also tagged with a radioactive signal that allows us to see where it goes. And so when you inject it, if a person has amyloid in the brain, it sticks to amyloid and then lights up. And that's what this image here shows. We can do the same thing for tau, which is what is shown on this side. Amyloid imaging was approved about 6 years ago, but it remains inaccessible because of cost. Tau PET imaging was approved in May last year by the FDA, but that news flew under the radar for reasons that we all know, the pandemic. But these two technologies are game changers, because in the past, making a diagnosis of Alzheimer's disease or any other dementia has been, to some degree, discounting other potential causes like thyroid disease, for example. Now we can actually make an affirmative diagnosis, and we're now on our way to being able to develop tests that specifically ask the question, does this person have Alzheimer's disease? Okay, so what are we doing today when we make the diagnosis? We have, the way I see it, when somebody comes with a memory complaint, they're coming with either a problem that they don't understand, in which case our job is to make a diagnosis, or they're coming with a crisis because they've been failing at work, for example, and their job is under threat. So we have to help solve that problem. There might be distress because they have symptoms that are associated with the condition, for example, high degree of anxiety, depression, in some cases, hallucinations, in which case we'll be providing relief. And then there is, of course, demoralization as we on account of the impact of the problem and on account of the diagnosis when we make it. And so our challenge then is to provide guidance, to instill some hope, to bring clarification and support, and also to provide direction about what to do. So this is the role that I find myself in. And the emphasis varies from person to person, whether I'm going to be emphasizing diagnosis or solving problems or trying to provide guidance. What do we do beyond that? We're not yet able to do curative interventions. So much of what we're doing focuses on ameliorating the symptoms, trying to slow down the progression of disease. So we have medicines to try to do that, to slow down the progression of symptoms as opposed to the neurodegeneration. And we hope to be able to eventually slow the neurodegenerative process itself, which will move us in the direction of cure. We have rehabilitative intervention. Some of that is cognitive rehabilitation to help people practice cognitive skills. Some of that is to help people develop alternative skills or strengthen alternative skills so that they can remain functioning in their lives. And then when we talk about palliative care, this is to be distinguished from end-of-life care. Palliative care is essentially emphasizing comfort, emphasizing dignity. It does not necessarily follow that we're preparing for the end. So this may include dietary interventions to help people keep up their physical fitness. It may involve home services and equipment to mitigate the disabilities and sometimes to compensate for lost skills. So for example, if a person can't go up the stairs, we might provide a lift. So that would be a device intended to improve quality of life. This is the working model. It says here FTD evolution. FTD is a different kind of dementia, but this is essentially inspired. This diagram you see here is inspired by the model for Alzheimer's disease. And this slide was just more available to me, so I used this one. So let's think of this as AD here rather than FTLD. What is happening is that over a period of decades, a person has a clinical status that up until this line we would call normal. Here they have minor complaints that do not rise to the level of dementia, and then they cross this line, at which point there's a cognitive decline that is an unmistakable dementia. But brain volume, the brain shrinkage that associated with dementia begins earlier and can be detected in this transition stage, even when the person clinically is still performing well. And then there's a buildup of molecular pathologies, including neurofilament, which tends to accelerate at the time the person is transitioning from normal to abnormal to an abnormal cognitive state or clinical state. And then you have inflammation in the brain. So the value of thinking about this is to understand that there are things that we can do in advance of losing brain tissue, at least of losing brain tissue beyond the threshold, in advance of developing dementia. There are things that we can target in terms of the molecular pathology and along the lines of what I showed you: dietary interventions, sleep hygiene, treatment, detection and treatment of hypertension, healthy diets. These are mindful diets. These are the kinds of things that allow us to change the trajectory of this pathology here, which we expect to change both the trajectory of neurofilament buildup, neuroinflammation, and brain volume decline. And the goal is to move this line, all the way here and eventually to make it go away altogether. So that's where we are today in terms of the science. I should also mention that there are advocacy groups out there supporting people with dementia, the Alzheimer's Association, the Association for Frontotemporal Degeneration, and others. So there's a lot to be done, and there's a lot that's being done today. This model that I have shown you is, people are working at a more molecular level with, identifying these molecular pathologies so that we can identify, design the drugs to interrupt them. But until those drugs are here, the effort is going to be, a lot of the effort has to be preventive along the lines of what I've mentioned. So thank you for your attention. I'll stop here and take your questions.
Thank you so very much. It has been an absolute pleasure to have you here with us to share such brilliance, Dr. Chiadi Onyike. Thank you so much for your brilliance. You have touched my heart in places you cannot imagine, both from the pathology that you shared to the legislative advocacy with which you close. They all touched my own background in experimental pathology, in research, a tremendous amount of work that we've done in the space of the formation of amyloidosis and those plaques in the brain, and just absolutely appreciate the well-roundedness of your conversation to not only teach and educate us about what happens from your medical diagnosis side, but then to really drive home the point that there's a lot that we can do to be preventative, which has been a theme here on Medical Mondays, the power of prevention, to be curative and to move ourselves forward with actionable items should we find ourselves or our loved ones having to face this diagnosis of Alzheimer's or having some form of trauma or some form of brain injury and degeneration. So just thank you on behalf of our audience and you. Before I go to the chat box and open question and answer to our audience, I want to defer to Dr. O because I know she wants to share her enthusiasm for your presentation, and she always asks the best questions. Dr. O?
Thank you so much. That was awesome. Much needed now, because for reasons you have cited, and maybe more that we don't know, there is increase in dementia. It could be Alzheimer's, other dementias, there is an increase. So there's a reason why definitely. And we're relying on you, especially at Johns Hopkins, for you guys to come up with answers. But I want to ask you, so people say when people multitask and they do several things together, that they have higher potentials, or they can more likely develop dementia. Is that true?
I don't know of any evidence that that is true, that multitasking puts us at higher risk, or puts anyone at higher risk for dementia. And in fact, the evidence, as you're well aware, there are many professions, particularly professions at which people sit at their desk, that place a very high demand on multitasking. Even the act of parenting puts one at high, places a high demand on multitasking skills. What the evidence shows rather is that practice, in this case, you're practicing your executive function skills, is a bulwark, if you will. So there's evidence, for example, that shows that taxi drivers, even when they develop, taxi drivers have, for example, a much more robust cognition in terms of spatial orientation. And so even when they are faced with cognitive decline, they still perform better than their counterparts with similar levels of decline when it comes to finding their way. And that's because, as you know, a taxi driver has to have large maps, libraries of maps, and they have to maps in their brain regarding geography. They're very practiced at finding their way, at memorizing cues and the like. The same is true for all of us, that the skills we practice regularly become become increasingly robust. And some of this probably has to do with strengthening of synaptic connections. So the nerve cells that observe these functions, when they work consistently, their connections get stronger. You could think maybe a very crude analogy is, or a crude slogan is, use it or lose it. But also, if you know from exercise, you don't build muscle by sitting around and resting. You build it by using it.
Thank you. That's why we encourage reading, because that helps to build cognition. I have one more question, and then I'm going to defer to the chat box. So you mentioned diet, exercise. This is what we've talked about every Monday. Everything we do rests on good diet and exercise. So in order to prevent this, because prevention is always better than looking for a cure. We don't have a cure for cognitive issues as of now. So in order to prevent, please say some more about diet and exercise.
So there is some evidence for, there are people exploring the various lines of evidence. Well, at a very basic level, the poor diet predisposes to obesity, predisposes to hypertension, it predisposes to diabetes, and these are independent problems for the brain and for the body more generally. So at a very first level, optimizing one's diet and physical cardiorespiratory fitness reduces the likelihood of developing hypertension. In some cases, it can actually reverse hypertension if one is successful, for example, in losing weight, if one is overweight. So that's one aspect. It takes away those other risk factors. There are also some lines of evidence suggesting that some people have referred to Alzheimer's disease, for example, as brain diabetes. The evidence is still not, I wouldn't call it compelling, but there are findings from animal research showing that reducing food intake results in the animals learning the tasks better, and giving them more activity. In this case, putting mice on a sort of treadmill also makes them cognitively sharper. At least based on results from testing their ability to find food from various locations. So what that means, therefore, is that maybe glucose excess is not just harmful for the waistline, or for the heart, but also for the brain. So in other words, there are compelling reasons to manage diet. Firstly, to eliminate other risk factors. Secondly, to deal with brain physiology directly. And the evidence seems to suggest that reducing carbohydrate intake is actually healthy.
Thank you.
That is absolutely brilliant. And thank you, Dr. O, for those outstanding questions. I think it is absolutely the point that we are driving home here on Medical Mondays, the power of prevention, and encouraging, supporting, and driving our audience and more to really understand the power of prevention. So thank you both. We have some wonderful questions in the chat box. And if there's anyone who wants to ask their question live, please do raise your hand so that we can acknowledge you. First, before I ask the questions, Dr. Onyike, I want to be sure to let you hear some of the comments. Wow, great presentation. Thanks for your brilliant presentation. Thank you, Dr. Onyike. Just continued lauding of how exceptional your conversation has been. So our first question, is there any significant correlation between a reckless lifestyle choices such as drugs and alcohol and dementia?
Well, the answer, as is the case with many things, is yes and no. So with alcohol, which I think is the big one here, chronic alcohol abuse or misuse definitely leads to cognitive decline in its own right. There is some indication that stopping, that if one becomes fully abstinent, that risk diminishes, and in many cases will go away completely. But that is the case when the person hasn't developed cognitive decline from the drinking. Once the cognitive decline is established, it's not reversed. So that's one aspect. Now, with respect to, say, cocaine, heroin, and other recreational substances, there is no evidence that I know of that addictions to those substances will lead or predispose a person to dementia, except to the extent that it causes them to neglect their health more generally. Now, cocaine, maybe there's a caveat to what I've just said, which is that some people's cocaine addiction is severe enough that it leads to them developing strokes, and in which case their cognition will be eroded by the strokes, but it will not be an ongoing problem. So they might have a stroke, they'll have another if they continue to use. If they stop, they'll have the effects of that stroke, but they won't necessarily be at higher risk for a neurodegenerative process like Alzheimer's disease. But they may be at higher risk for expressing symptoms because their threshold has been diminished if they've had a stroke.
Beautiful. Another attendee asked, is there a direct correlation between high fructose corn syrup consumption and amyloidosis?
None that I know of.
Wonderful. Oh, please go right ahead.
No, go on, sorry.
Another participant commented that they're saying, oh my goodness, poor diet and no sleep equals poor health. And so I would like to add on to those, to the conversation that we're having about prevention, as well as to go back and highlight some of the symptoms. You shared something that was new knowledge for me, where you said that it is not the memory loss alone that is the first sign of problems. Sometimes you can develop over time space-time issues, speech, and other symptoms. Can you just give us a little bit more practical knowledge that we can leave this conversation with about signs and symptoms of either Alzheimer's and dementia or both?
Okay, yes, I can do that. Now, there is a question that follows the one you've just put forward, which is how is Alzheimer's different from dementia? So I'll take them together, that part of that question along with this. There's more to that question that we can deal with later. So dementia basically means that a person has lost their cognitive abilities. That's just a statement. So you can lose cognitive abilities, for example, if you've had trauma, car crash, or assault. or some other accident. That will result in dementia. So dementia is basically the state of having lost cognitive abilities to a point that it interferes with a person's ability to manage their life as they have been doing. That's what dementia is. Alzheimer's disease is one of the causes. It is associated with specific molecular findings, which I noted earlier, in particular amyloid deposition in the amyloid, accumulation of amyloid and tau in the brains, in the amyloid around the brain cells, tau within the brain cells. There are other causes of dementia in which the accumulation isn't about amyloid. It's about some other inclusion body or some other protein abnormality in the brain. Alpha-synuclein, for example, Lewy body dementia. There are other isoforms of tau that accumulate in some forms of frontotemporal dementia. There's what we call TDP43 protein that accumulates in some other forms of frontotemporal dementia, and so on. Now, in the beginning, people will have some cognitive complaint. What is best known is memory, forgetting, typically of recent things. Or in the beginning, it's usually the details rather than the whole thing. So a person might go to a wedding and forget some of the details. In time, it progresses. But a person can also develop dementia where the first complaint is that they can't see. So we've seen this frequently. And what is happening is that they have trouble processing visual information. So the eyes are fine, but their use of visual cues has become impaired. Sometimes the problem is that the person has speech difficulties, so they have trouble finding words with which to present their ideas. And so they stutter, they hesitate, they grope around for a word to speak. And so the speech becomes somewhat disjointed. And I frequently see people in whom that is the first problem. They have a problem with speech. Now, how do we recognize this in the beginning, perhaps when it is subtle? When it is, because after all, sometimes I go downstairs and I remember I forgot my keys and I dash back upstairs to get my keys. So that's not an early sign. Sometimes you're in the kitchen and you wonder, why did I come here again? That's not an early sign. Where it becomes a problem is when it's an everyday observation. It's consistent and it's beginning to interfere with everyday activities very frequently. So if you're continually misplacing things all day long, every day, then maybe there is a problem. But if it's, you're telling a story and you're trying to remember the name of that movie and you're snapping your fingers, what's that movie? That's not necessarily a sign. But if it is happening very frequently, and especially if it's happening in areas where you shouldn't have that struggle. For example, you're trying to remember your child's name. That is a problem. Or your sibling's name. That is a problem. If you're trying to remember what an everyday object is called, that would be viewed as a problem. So hand me and you're snapping your fingers when you're referring to a fork or a spoon. That is a problem. So we take it from the frequency and we take it from the nature of it. Some things are understandable, like where did I leave my keys? Where's my wallet? Other things are more difficult to understand.
And then what's the first thing that we should do when we either observe in another person, family member or the like, or we start to realize we're having some issues? What's the first thing we should do?
I think the first thing to do would be to have a chat with the primary physician. Because sometimes we're more worried than we need to be. Maybe have a chat with people around us. It's possible to be more worried than you ought to be. If, for example, you've taken care of a relative who has dementia, you're exhausted. Your attention, you're less attentive. You might forget things that you ordinarily would not forget, or make mistakes you might ordinarily not make, and become worried. And it's helpful to talk to people to gain perspective. But if you may also seek an appointment with the primary physician, who will then help in determining whether a referral is necessary for more in-depth investigation. Now, if you observe it in someone else, what I would say is that the first step, obviously, is to talk to them and ask and inquire as to whether they have noticed themselves. And then they may not have, in which case you point out your observations and then have a conversation around it. But the hope would be to persuade them, if it seems serious, to seek an evaluation.
That is excellent, Dr. Onyike. We appreciate you so much for being on today's show. Before we have a Medical Mondays moment with Dr. O and close today's show, I'd like to extend to you the opportunity to give your closing comments to our audience.
Okay, so I'd like to take that last question quickly about the smell. It's true that the sense of smell is lost in Alzheimer's disease, but it is not being used to detect Alzheimer's disease. And the reason for that is because, as you know, pollen counts are higher and higher, and seasonal allergies are common. All sorts of respiratory things can interfere with smell, so it makes it unreliable. It's not similar to the COVID-19 source of smell because it's not abrupt, it's insidious. People with COVID-19 know immediately. It's like yesterday it was fine and today it's not. What I'd like to say in closing is that, the burden of aging and the cognitive changes that are associated with aging are not necessarily Alzheimer's disease or dementia. So that's important to know. Aging is not equivalent, does not inevitably lead to senility. That's very important as well. Dementia is not senility, so it should not be dismissed as such. If you start to notice problems, it's important to seek in yourself or in a relative to help them seek an evaluation, because sometimes there are other things that can mimic Alzheimer's disease. I mentioned thyroid disease earlier. There are other things besides, and there's treatment for that. So we don't want to give up too soon. Even where it may be Alzheimer's disease, there's treatment, or treatments that can help. But the most important thing, as we've talked about already, is to maintain our bodies and our minds. We only have this one. We're not going to be able to trade it in. It's not like a car or a house where you can upgrade or trade in. So we have to start now to take care of ourselves, because very often when people are seeking care and they're told lose weight, they already have the problem, and it is difficult to do it at that point. So the results are best when you do them before you have any symptoms of anything. And so anyway, that's what I would say. Thank you for your time, for your attention, for the invitation, and for the very kind reception. Appreciate it.
Thank you so much, Dr. Onyike. We are excited to have had the privilege of an esteemed leading professor and expert here on Medical Mondays. I am now going to go to Dr. O to share with us our Medical Mondays comment for the day.
Thank you so much again for speaking English in educating us on brain health. This has been amazing. I learned a lot, and I learned that, again, diet and exercise is very important with sleep in controlling or preventing possible issues with brain health. So again, we always circle back to the same thing: diet, exercise, good sleep. Thank you so much for that education and for your time. God bless you.
Thank you. Thank you.
Thank you so much to our audience, to Dr. Onyike, and to Dr. O. As we continue our mission to educate, inspire, and empower you, and give you medical information and so much more, this includes our ability to teach us about fitness, nutrition, health, wellness, and all the things that can boost our lifestyle, our joy, and our peace for our souls. Please share the Medical Mondays link and invite your friends, family, faith-based nonprofit and community organizations, and individuals in your communities to join us. Email us if you have any questions or need additional information or desire to follow up with our experts at medicalmondaysdro@gmail.com. Please subscribe to our Medical Mondays channel on YouTube and be sure to hit the notification bell on the page. You'll then be notified of all of our future shows and can join us with one click of a button. And most importantly, remember our mantra, strong health, strong future. We look forward to our next conversation, and this concludes tonight's edition of Medical Mondays. Thank you all, and good night.